time, we want to welcome you to this third in our series of 4 CCS webinars focused on the heart failure guidelines. And on behalf of my colleagues in the CCS and the CHFS and the heart failure guidelines panel, we hope this is going to be a really stimulating and rewarding discussion regarding device therapy. So this webinar is really going to focus on managing more complex heart failure patients beyond medical therapy. When do we consider heart failure devices like resynchronization therapy and implantable defibrillators? Next slide, please. So I'm one of your 2 moderators for the evening. That's me, Mike McDonald, from the University of Toronto. I'm a heart failure transplant cardiologist based out of the Peter Munck Cardiac Center. And my co-moderator is on the next slide, Dr. Sherry Coachman from the University of Alberta. And Sherry's an associate professor in the Division of Cardiology at the Mazankowski Alberta Heart Institute and clinically works in the Heart Function Clinic. Next slide, please. Again, we want to thank people for their time and participation in the webinar series and are looking forward to the discussion. Before we begin, we do, wherever you are, want to take a moment by way of land acknowledgement, and we just ask that you take a moment in your thoughts to acknowledge the traditional territory of the Indigenous people, again, wherever you may be across the country. That in mind, we'll move to our next slide again. So as I mentioned, this is the third in a series of 4 webinars related to the heart failure guidelines. So the first webinar was a few weeks back, and that really focused on what's new in the 2021 HFrEF guidelines. The second webinar looked at screening and diagnosis of HFrEF and heart failure with preserved ejection fraction, or HFpEF. Today's focus is going to be on device therapy. And then a plug to attend and register for the 4th of 4 webinar series on the non-pharmacologic management of heart failure patients, and that's July 15th, again with another outstanding faculty and set of presentations. Next slide, please. And in terms of housekeeping activities, the webinar is accredited by as a group learning activity by the MOC program of the Royal College, and it's approved by the Canadian Cardiovascular Society. You can claim up to an hour of MOC credits for this. And then importantly, probably the most important part of the webinar is that after our brief presentations, we're going to have a lot of time for question and answer, and we encourage people to type their questions in the question box in the GoToWebinar control panel. And we'd like you to think of your questions. You can save them to the end or ask them in real time. We'll keep a running tally as we go, and we'll have lots of constructive discussion at the end of the presentations. Next slide, please. So I've introduced myself and my co-moderator for the evening. Our faculty also includes Dr. Anik Ducharme from the Montreal Heart Institute. Anik is well known nationally and internationally. She's a cardiologist with an interest and clinical expertise in heart failure, heart transplant, echocardiography. She's also the current Madam President of the Canadian Heart Failure Society. Our colleague, Dr. Mustafa Toma, is from the University of British Columbia and based out of St. Paul's. He's a cardiologist with expertise in advanced heart failure and transplantation. He's a member of our Canadian Cardiac Transplant Network executive, and he chairs and runs an exceptional heart failure symposia out of BC every year. Next slide, please. Here's our potential conflicts of interest. Again, these are all available on ccs.ca website. Next slide, please. So the overall learning objectives for the program are really to review the indications for device therapy in heart failure, and also explore the risks of sudden death in the current era, where we could think of more intensive or comprehensive guideline-directed medical therapy for low EF heart failure patients. And then from that, what is the optimal timing in our current era for referring for devices? So that's what we hope to get at and have some discussion about tonight. Next slide, please.
Okay.
I'm going to turn it over to Dr. HFWhen to present the cases.
Okay, so we thought we'd kick off this session with a couple of cases to get your heads thinking about those patients that are in front of you. So we're going to start off with case number 1, and these are real life cases. So it's a 51-year-old female. She's had a prior MI with a late PCI to her LAD. She does have some comorbidities, including type 2 diabetes with a hemoglobin A1C of 6.6%. And she was recently hospitalized for new onset heart failure about 4 months ago. Investigation showed that her stent was patent and there was no new coronary disease. She did have an echo. Her echo revealed EF of 30 to 35%. Functionally, she was New York Heart Association class 2. And she's being referred for consideration of ICD implantation. Her ECG reveals a narrow complex QRS. And in terms of vitals, she has a heart rate of 78 to 82 beats per minute. Her blood pressure is okay at 110 on 70, and your fluid assessment reveals that she's euvolemic. In terms of her medical management, she has decent medications. She's on bisoprolol 10, spironolactone 25, sacubitril valsartan 4951, empagliflozin, and metformin for diabetes. So what do you guys think that we should offer her next? And we have a little poll for you to participate in. So tell us what you think. So I actually cannot see these poll results, but I'm told that the majority of people selected option 3 at about 47%. So increase the valsartan sacubitril dose. And next slide. So what about case, we'll move on to another case for you to think about just as a different approach. And we'll revisit these at the end after we give you a little bit of food for thought and see where you guys are at. So case number 2 is a little bit of an older gentleman, so an 83-year-old male. He was diagnosed with HFrEF about 3 months ago as an outpatient. His EF was 30% at diagnosis, but he was also found to have severe functional MR with right-sided pressures of 60 millimeters of mercury. He did have a cath which showed normal coronaries, and in terms of comorbidities, he has moderate COPD. He has chronic kidney disease with a baseline creatinine of 120. He does have a past history of prostate cancer, and currently he has persistent class 3 symptoms. In terms of his vitals, his heart rate is 60 to 66. Blood pressure is a little soft, 95 on 60, but his fluid assessment is euvolemic. When we evaluate his medications that he's on sacubitril valsartan on a lowish dose. We did try and up-titrate that, but he was unable to tolerate that, secondary to lightheadedness. He's on carvedilol 12.5 BID, so lowish dose, spironolactone 25, dapagliflozin 5 milligrams per day because he was intolerant of 10, so that needed to be decreased. And he's on a low dose of diuretics of furosemide 20. And you can see his ECG there. He does have a wide QRS. So in this case, which is a little different than the first case, what would you offer this gentleman? Okay, now I can see my poll here. So it looks like we're a little bit split on the decision. We have some people saying CRT plus or minus pacemaker defibrillator. A few people noting MitraClip might be an option, but not that many people supporting digoxin, and a few that think perhaps this gentleman needs to be put in contact with palliative care. So kind of a mixed bag from our group. Next slide. So it's at this point in time, I'd like to invite Anik to speak to us and give us a little bit of data to then round out our discussion on these cases.
Can you hear me now?
Yes, can hear you now.
Yeah,
Sorry.
we can hear you now, and yeah.
Okay, I was unmuted. I'm sorry. I don't know what happened. So my task is to discuss the risks of sudden death and basically a controversy. Didn't know I was a controversial person, but anyway, surrounding the relative benefits of ICDs. I can have the next slide, please. So basically, there's two things I want to achieve in the next 9 minutes or so is to evaluate the risk of cardiac death for a patient treated with contemporary therapies like the treatment of 2021 and try to convince you that 2% is the new 8%. So the next slide, please. Well, first of all, when we consider an ICD referral for primary prevention of sudden cardiac death, we are facing a difficult dilemma of, on one side, in green, the early referral to avoid sudden cardiac death risk in our patients. But this is at the cost of potentially implanting unnecessary devices with potential related complication by doing so too early, that is, before optimization of guideline-derived medical therapy. Furthermore, we will need to ensure that GDMT is optimized after ICD implantation. Next slide, please. So I'm going to try to bust a few myths. First one is current heart failure therapy has not done much to decrease the rate of sudden cardiac death, and therefore we should refer early for ICD. Next slide, please. I think you've seen that slide over and over again. It's 22 years old. It's older than my son, as a matter of fact. And this shows the mode of death. When you're at the right side, the NYHA class 4, the chances of dying of either progressive heart failure or comorbidities are 2/3. So probably preventing sudden death might not be a first option here. At the other end of the spectrum, on the left, you have the NYHA class 2 patients, whereas Their mortality rate is much lower, but a 2/3 died suddenly. Next slide, please. There's been multiple RCT of primary prevention of sudden cardiac death with an ICD. They provided robust evidence of incremental mortality benefits over guideline-based medical therapy in patients with ischemic on the left and non-ischemic cardiomyopathy on the right when they had a reduced ejection fraction. The LVEF was below 35% in SCOT-F. Well, based on these trials that were published between 2002 and 2012, primary prevention ICD continue to be recommended in current international guidelines. Wait a second, good background therapy at the time was ACE or ARBs in 87% of the patient, beta blocker in 78%. Next slide, please. Well, it's important to realize that both sudden death and total mortality have decreased dramatically in heart failure patients with the improvement in medical therapy since these legacy ICD trials. A recent analysis of drug trial in FREF patient, including more than 40,000 patients enrolled in 12 clinical trials between 1995 and 2014, showed that 44% decline in sudden cardiac death across the trial. You see on the left hand the RAILS trial to the ARNI trial paradigm. The annual rate of sudden death per 100 patient year in the treatment arm decreased from 5.4% in RAILS to 3% in long-term follow-up. And these trends are attributed to the sequential introduction of ACE, beta blocker, ARBs, and MRA. So the dramatic decrease in the risk of sudden death in recent heart failure trial has and I think reasonable questioning regarding the continued survival benefits of primary prevention ICDs in this patient population. Next slide, please. So maybe we need to consider the relative benefit of ICD in the current era. Next slide, please. I think in patients with ischemic heart disease, ICD implantation have been shown to reduce the rate of sudden cardiac death and overall mortality in a number of trials. However, the benefit is less clear, I think, for non-ischemic heart disease. This is the data from the Danish trial, and there was a lack of improved survival among patients with non-ischemic cardiomyopathy with high rate of GDMT and cardiac resynchronization therapy in this trial. There was very few patients on ARNI and no SGLT2 in Danish. Next slide, please. So the second myth I want to debunk is basically there's very little added benefit of the 4 pillar for improving LVEF beyond beta blocker and ACE inhibitor. I've been told by my colleagues, do you really believe that the EF is going to go beyond 35? Well, it's not a belief, it's fact. Can we get the next slide, please? This slide is also quite old, but it shows that only with ACE and beta blocker, 25% of patients with reduced ejection fraction will improve their EF above the 35% threshold for primary prevention ICD. Next slide, please. The third myth is the timing of ICD is not very important as long as patients are optimized on GDMT after, and this is done on a regular basis. Next slide, please. Well, unfortunately, this is not the reality. The graph on the left is from a large Medicare registry that showed that at best, 75% of patients were on beta blocker at the time of ICD implantation for primary prevention. 40% of these patients were not receiving any GDMT at time of implant. On the right panel, from the same registry, we can see that less than 30% in blue who had an ICD implanted were receiving the 3 classes of beta blocker, ACE, and MRA. And we're not talking about ARNI here, and certainly not about SGLT2, which is the contemporary treatment of heart failure nowadays. Can I have the next slide, please? Well, although the LVEF has important prognostic value, accurate risk stratification regarding sudden cardiac death remain a challenge. We know that patients on the green who have a high risk of sudden cardiac death do benefit most from ICD, whereas patients with many comorbidity probably benefit less. Interestingly, most patients with dilated cardiomyopathy who experience sudden cardiac death do not necessarily have more severely reduced LV systolic function. In addition to LVEF, there's a number of other risk stratification tools that have been used in the past to predict sudden cardiac death in both ischemic and non-ischemic cardiomyopathy. You can find them online, but unfortunately, none of these has clearly been proven to be helpful to accurately predict the risk of sudden cardiac death in the patient you have in front of you. With the exception probably of the myocardial fibrosis as seen by late gadolinium enhancement, DLG, on cardiac MRI. This has been very strongly correlated with an increased risk of sudden cardiac death in patients with dilated cardiomyopathy. Next slide, please. Well, back to my cases. Very interesting. ICD for all. There's a special today. Well, I think the guidelines are pretty clear. 4 medications. The risk of these patients now on the 4 pillars of sudden cardiac death is about 2% annually, or like we divided dramatically since the old slide that we keep showing and I showed you today. Then you reassess the patient, look for the LVEF, and for primary prevention ICD, if it remains below 35%. And Mustafa is going to explain us how we can find that. Then it's time to consider. So there's no rush for primary prevention ICD. So I'll turn the floor or the mouse to Mustafa. Next slide, please. So Dr. Tama, you're going to teach us about remodeling and how we can avoid those ICD or put it in the patient that needs it. Thank you very much.
Well, thank you very much, Anik, for that nice presentation about the risk of sudden death in these patients and how it's gotten better. And now over the next few minutes, I'm going to talk about why novel heart failure therapies will even further potentially reduce the risk of sudden death in these patients. Next slide, please. And so by way of introduction, my learning objectives are listed. I will try to review the evidence for reverse remodeling with the new heart failure therapies that we have available to us in 2021 and that have been highlighted in the new heart failure guidelines that were published recently. And secondly, I would like to discuss the timing of device implantation using the new heart failure algorithm, which has been touched upon briefly by Dr. Ducharme a few minutes ago. And next slide, please. So the current novel approach to contemporary management of heart failure with reduced EF patients is to start with the 4 pillars of treatment, which is an ARNI ACE inhibitor or ARB, along with the beta blocker MRA and SGLT2 inhibitor, and then look at the second tier therapies, ivabradine, vericiguat, digoxin, hydralazine, nitrates, and then reassess LVEF once the patient has been stabilized and optimized with medical therapy before assessing for further treatment options like devices or advanced heart failure therapies or referral to palliative care. And some may question why the order was done this way. And part of it, of course, is related to the decreasing risks of sudden death, but also part of it is because what I would try to highlight for you is that some of these therapies that are placed higher up in the algorithm can improve LVEF and can reduce LV volumes and size to the point where patients will no longer be at that risk of sudden death with an EF of more than 35%. And next slide, please. And so the timing for referral of device therapy has to strike a balance, as Dr. Ducharme mentioned. We need to determine, well, what is the risk of sudden death in that individual patient versus, you know, I need time to up-titrate medical therapy in order to improve LVEF. But then the patient may say, well, listen, doc, I don't want to get a device because there's a risk of device-related complication like infections, like perforation, or like lead dislodgement, for instance, which is not an insignificant risk associated with device implantation. And then we have to weigh that once again against the potential intolerance to medical therapy. So you spend all this time trying to initiate and up-titrate medications, but the patient ultimately will be unable to tolerate the maximum doses or may need to stop some of the medications. And as the case is highlighted, you know, Mike's second patient couldn't tolerate maximal, you know, therapies of ARNIs and SGLT2 inhibitors. And, you know, is that time wasted potentially in that algorithm scheme to up-titrate medical therapy? Obviously, patient preference has to be weighed, and maybe even at a more preferential level, in order that we appreciate and respect patient preference. And I think ultimately what needs to happen is we need to personalize the therapy to the individual patients. And I'll come back to this maybe towards the end of my presentation. And I'm sure there are other factors that I did not even address in this slide with respect to risks and benefits and weighing those for patients. Next slide. So this is a different slide, a little bit more contemporary than the one that Dr. Ducharme showed, perhaps, about what happens to LVEF following initial diagnosis of heart failure. And this data comes from the Swedish Heart Failure Registry. It had almost 5,000 patients, and they had at least 2 measurements of LVEF over a period of time. And what they showed in the study is that one, about 2/3 of patients had heart failure with reduced ejection fraction at baseline, so that's an LVEF of less than 35%, or sorry, 40%, I should say. About 18% of patients had heart failure with preserved ejection fraction, and the remaining 19% had heart failure with mid-range EF. And when we look here at the different bar graphs, we look at the colors representing what is the follow-up EF. And in blue, it's heart failure with preserved EF. In yellow, it's heart failure with mid-range or mildly reduced EF. And in red, it's heart failure with reduced EF. And I think what's important to highlight is a few things. One is that in the HFpEF patients, 18% of patients will drop to 35%, sorry, to less than 40%, which would necessitate the need for optimization of heart failure therapies. But if we focus on this green square or rectangle, I should say, here on the right side, is that when we look at patients who are referred to clinics in the Swedish Heart Failure Registry and they have a low EF at baseline, about 25% of these patients will improve their LVEF to the mid-range, which is in 16% of patients, and the preserved, which is greater than 50%, in 10% of these patients. And what this needs to highlight is that novel therapies may even improve this further, because by the time this was published, I would argue that SGLT2 inhibitors and ARNIs were not used as extensively as they are today. I think we also need to highlight, and I just put this in text form, is that the majority of device trials were done prior to the era of novel heart failure therapies, and that needs to be always taken into context when we think about the risks and benefits of medications and device implantation. Next slide, please. So what does the evidence tell us about LVEF change and reverse remodeling in patients with heart failure and reduced ejection fraction using novel therapies? So with respect to ARNI, the PROVE-HF study, which was published in 2019, and it was a late-breaking trial at the ESC in 2019, looked at 794 patients who had either de novo heart failure or pre-existing heart failure, and they were at that point in time switched to an ARNI. So the de novo patients were started on an ARNI from the get-go, whereas the ones with pre-existing heart failure who are on an ACE or ARB to start off with were switched to an ARNI. And these patients had a baseline echo, and then subsequently they had 2 echoes at 6 months and 12 months. And what the slide highlights is that in patients specifically who were switched to an ARNI, what we see on the left side is that the LV end-diastolic volume index was reduced significantly from baseline to 6 months and 12 months. And similarly, the LVF increased quite impressively from 28% at baseline to 33.8% at 6 months, which was statistically significant, and up to 37% at 1 year after initiation of an ARNI. This is not a randomized study comparing 2 therapies. This is just a switching from an ACE or ARB to an ARNI, and so there may be some limitations to that. But nonetheless, this clearly shows that ARNIs have a potential of improving LVEF in a substantial proportion of patients. Next slide, please. And similarly, more contemporary even data published recently this year looked at the potential benefits of empagliflozin, or an SGLT2 inhibitor, of course, in terms of improving LVEF in patients with HFrEF who are non-diabetics. And in this study, what they did is they looked at 84 patients who were randomized to either empagliflozin 10 milligrams daily or placebo, and they had baseline LVEF assessments and then subsequent LVEF assessment by cardiac MRI. And what they showed was that, similar to the ARNI data, a substantial reduction in LV end-diastolic volume was occurred in those who were treated with empagliflozin in the blue bars in the top left graphic compared to placebo, where there's no change in LV end-diastolic volume. And similarly, LV end-systolic volume was reduced in the top right bar graph. And in the middle left bar graph, which I think is the one that most of us kind of pay close attention to, is the change in LVEF. And what we can see here is that there was a 6% absolute increase or improvement in LVEF from baseline to 6 months of treatment with an ARNI. And this is very impressive, of course, so highlighting that we definitely should initiate an ARNI before we reassess LVEF and consider devices, in my opinion. There's other potential beneficial effects that I'm not going to go into, but they were also highlighted in the study. And we'll go to the next slide, please. And this slide looks at a little bit of older data, but probably some of the more robust data in terms of change in LVEF with the relatively novel, although not so new anymore, therapies in terms of ivabradine. And in the ivabradine study, what they did is they did a sub-study of approximately 400 patients, and they had baseline echoes and then subsequent echoes at 8 months after randomization. And so this was a nice randomized study that had core lab assessment of echocardiograms in a subset of their patients. And what they showed was that, similar to the previous 2 slides that I showed, that ivabradine reduced LV end-systolic volume index by an absolute value of 7 from baseline to 8 months, compared to placebo, in which there was only very minimal change in LV end-systolic volume index, and the absolute difference between the two ends up being 5.8. And similarly, on the right side, what we see is a change in LVEF, and in the ivabradine group, there was a 2.4% absolute increase in LVEF compared to placebo, where there is essentially no change in LVEF. So once again, highlighting the importance of initiating this treatment in those patients who are eligible based on the shift inclusion criteria and what we have previously recommended for ivabradine use in patients with HFrEF. And next slide, please. And in this other graphic from the same paper, what they showed is the proportion of patients who had a change in their LVEF. And so what we can see here is that in the ivabradine group, there were less patients compared to placebo who had a reduction in LVEF, who had an improvement in LVEF of, a reduction in LVEF of 5% or so. There were less patients who had minimal change in LVEF of less than 5 plus 5%, but there was a significant proportion of patients, 13% of patients had an absolute increase of LVEF of more than 5% from baseline to 8 months. So not an insignificant. So that's 1 in 6 patients essentially will have an LVEF improvement of more than 5% compared to placebo. Next slide, please. So why I put this slide just to highlight, and I think it's been shown in other presentations with the heart failure guidelines presentations, and similar to what Dr. Anik Ducharme showed earlier too, is that I think there's a missed opportunities to optimize medical therapy, and these missed opportunities lead to missed opportunities to improve LVEF. And so this data from the United States looked at ambulatory patients followed in cardiologists' offices, and what we can see is that in this graphic, it's a proportion of patients who are on target dose at baseline and 1 year in this registry, and only a small proportion of patients are at target doses of ACE inhibitors and beta blockers and MRAs at baseline. But what's sombering is that when these patients are cared by experts in the field of managing heart failure, specifically cardiologists, is that at 1 year, there's very minimal change in the proportion of patients reaching target doses of these life-saving therapies, but also therapies that can improve LVEF. And when we add SGLT2 inhibitors to this, obviously, that there's further opportunity for improvement in LVEF. So just highlighting that I think we can do better at optimizing medical therapy and adding new therapies like ARNIs, SGLT2 inhibitors, and ivabradine, medications that have been shown clearly to improve LVEF in this patient population. Next slide. And ultimately, how can we personalize care for these patients? Well, I think I don't want to dismiss the fact that there are going to be patients who are high risk and patients who are going to be at less risk of sudden death over time. And so obviously, what are some of the factors that we need to look at? So the slide on the picture on the left is a subgroup analysis of the Danish study that Dr. Ducharme highlighted. What we can see is that younger patients clearly had more benefit compared to older patients in terms of mortality reduction with an ICD. And so I think we do need to look at age of patients when we're thinking how much time do we have before we have to make a decision about ICD. Ischemic versus non-ischemic, we know that ischemics have a higher risk of sudden death than arrhythmia in general, and perhaps we need to be a little bit more aggressive in that patient population. Patient preference has to be weighed in, of course. The imaging factors, some patients in smaller rural settings may not have access to LVEF assessments. LVEF modality measurements, testing, imaging modalities may be limited, i.e. MUGA scan versus MRI versus echocardiogram, depending on where patients lives. Scar burden has been highlighted by Dr. Ducharme as well, is a predictor of sudden death, and that's not easy to get for the majority of patients. And obviously there are systems of care issues, i.e. some individuals, patients or physicians, for instance, may not have the ability to up-titrate patients to maximal tolerated quadruple therapy as foundational therapy, and then secondary therapies like ivabradine and others in a timely manner, and that needs to be taken into consideration before deciding whether patients should be assessed for ICDs or not. And similarly, there may be drug coverage and cost issues that may limit our abilities to optimize patients in a timely manner, and these needs to be taken into consideration, of course. Next slide. But when we take all this evidence into consideration that has been highlighted, the new recommendation is that after a diagnosis of heart failure with reduced ejection fraction, standard medical therapy should be initiated and titrated to target or maximally tolerated doses with a repeat assessment of LVEF prior to referral for ICD or CRT. And this was a strong recommendation with moderate quality of evidence. And we did leave some practical tips, and that reassessment of EF should be performed 3 months after achievement of target or maximally tolerated doses of GDMT. An assessment of arrhythmic and non-arrhythmic sudden cardiac death risk should be performed to estimate the risk benefit of an ICD CRT. Specific heart failure therapies may contribute to improvement in LVEF and should be considered prior to referral for ICD or CRT, and that includes patients who are eligible for an ARNI, for instance, or ivabradine. And referral for ICD or CRT should not be unduly delayed if timely titration of pharmacological therapies is infeasible or impractical, as has been highlighted previously as well. And I think my last slide's coming up, which goes over the new algorithm, in that after titration of guideline-directed medical therapy, that's when we reassess LVEF, we reassess symptoms, and we reassess clinical risk. And if the LVEF remains less than 35% and NYHA class 1 to 4 in an ambulatory patient, we would refer patients for a device like a CRT or ICD as per the CCS recommendations that have been highlighted. If the LVEF is greater than 35% and the patient is low risk, then we continue present management. And obviously, there will be a subset of patients who will have high symptom burden and will have high risk markers, and these patients will need to be referred to supportive or palliative care clinics or advanced heart failure therapies. Next slide. And I believe this ends the presentation portion of this webinar, and I believe Mike and Sherry will take over now. Thank you.
Okay, great job. Thank you so much, Dr. Thoma and Dr. Ducharme. It was an excellent presentation. What we thought we would do now, just to move on, is to keep things going and get right into the discussion. And we thought that we might just revisit the cases that we presented earlier. So let's start off with case 1. So recall, this was a younger gentleman who had ischemic cardiomyopathy, had a narrow complex QRS, had some room in terms of blood pressure and heart rate, and perhaps is not at target doses of GDMT. And the results from the poll was that the majority of people had selected to increase the sacubitril valsartan. I think that was about 47% had selected that option. So I wanted to go back to this case and see what our presenters think. What would they do, or what are the things that they'd be thinking about when they're making this decision between ICD referral and GDMT? So let's start with Dr. Ducharme.
Can you hear me now? Okay, thanks. So, well, I think for this case, I agree with half of the people. I think we need to increase the medication. Ivabradine is not a bad choice, giving a heart rate, but I would stick with sacubitril valsartan first and try to push the dose. We're just at intermediate dose here.
Dr. Thoma, do you agree, disagree?
I usually don't disagree with any, but this time I will. I think this patient clearly falls in that category that would benefit not just from an LVEF improvement, but also potentially from heart failure reduction and death, given their heart rate, NYHA class, and LVEF. I'm not sure that we know that there's a dose response relationship between the dose of the ARNI and LVEF improvement. I think they're on a moderate dose of sacubitril valsartan. I would just add the next line therapy here.
And Dr. McDonald, this was your case and your patient, and so tell us, what did you end up doing?
Well, you know, real life is always a little bit different than ideal life, and so you kind of nose up the medications that you can and try to get away with it. So this is a patient that actually nudged up the sacubitril valsartan. It's very interesting, actually, and then she started getting limiting side effects. So going up to the top dose of sacubitril valsartan, she started getting side effects of orthostatic lightheadedness that required us to drop the dose back. Be that as it may, ended up repeating an echocardiogram on her, and her EF was 45 to 50%. So I can't necessarily explain it. It's a little bit late for recovery of stunning, but you know, we avoided both the toxic effects of peak dose of a medication, and we avoided a device implant in her. So far so great, and she's sort of in that category of patients that's a little bit fortunate. This was a better than expected ejection fraction outcome for her.
Okay. Anyone have anything else to add? If not, I'll move on to the next case. Okay, so this case was a little bit different than the first one in that it was an older non-ischemic gentleman, multiple comorbidities, a little bit softer in terms of blood pressure and heart rate, and poor tolerability in terms of GDMT. This patient also had a widened QRS. So Dr. Toma, what would you do in this case? This was kind of the split in that people were choosing CRT pacemaker and CRT defibrillator, and then kind of a split between MitraClip and palliative care.
Yeah, no, this is a complicated case, and we deal with this quite a lot, of course. So the evidence for, it's kind of, to me, it's a process of elimination that works best for this one. I think digoxin is a good medication in those with refractory symptoms despite what you do, so the digoxin may be a good choice for improving reduction in hospitalization, let's say, which doesn't seem to be his major problem. I don't think he's been hospitalized frequently, but his issue is ongoing NYHA class 3 symptoms. And the MitraClip, I think, would be a reasonable option. However, our guidelines clearly indicate that MitraClip would be a last solution after everything else has been exhausted, both medically as well as from a CRT perspective. And this gentleman who has a non-ischemic cardiomyopathy with a very wide left bundle branch block, to me, should have a CRT, as it seems like all the other medical options that would improve LVEF have been utilized here. The question of a CRT pacemaker versus CRT defibrillator, however, is an interesting one. If we go by Danish, in an 83-year-old man, you could argue that he will not derive a mortality benefit from an ICD. You could argue that. However, I think this would be an individualized decision based on patient preference and based on what his really longevity is based on that prostate cancer that he has. So I think I would go with either C or D in this case.
And Dr. Deschamps, would you agree or disagree?
I hate to agree with Dr. Toma, but I think it's a question of preference for this patient. I would have liked to have the size of the LV. If the LV was very dilated, that the severe MR could be just proportionate and they derive less benefit from MitraClip. So I would just sit down the patient and say, have you ever thought that the way you want to die? And I find out, I don't know if it's a Quebec thing, but the majority of the patient above age 80, they all want to die suddenly in their bed. And so oftentimes the CRT, the defibrillator portion of CRT is not in question. The CRT-P is not used very much throughout the country and probably underutilized as these patients, like a juicy LBB. I think he has every reason to respond, and it's not unusual to see a decrease in functional MR after CRT. So I would, depending on patient preferences, either C or D.
Okay. And Dr. McDonald, what do you think?
So you're not going to let me off the hook on this one yet. So,
no.
Yeah, he's my patient, this guy, and he's known to me very recently. This is the current state of affairs, actually. So I was really hoping you could tell me exactly what I need to do for him. He's very resistant to coming into hospital. He's sort of very clear in his wishes that he would not want invasive therapies. I actually think he's a good candidate for both palliative care, and if he can get his head around it, perhaps a CRT pacemaker for him, based on goals of care discussions with him to date.
Okay. Thank you. I thought now we could maybe shift to some of the questions that we have in the chat or the questions. And so I'll just start off here. There's a question around the modality used to measure LV function. So the question was that MRI is not readily available. There's access to echo, MUGA, and MPI. Results are variable. What is the optimal way to measure and establish LV function before making these decisions to implant an ICD?
No one wants to take this on because there's no right answer.
Yeah.
You know,
Yep.
In a lot of studies that have looked at the utility of devices or what have you, echo is probably the most commonly used modality. However, a lot of studies or some studies do not stipulate the EF modality assessment. And so, you know, I think I've heard Dr. Zekowitz in the past say, and I hate to agree with him as well, is that you need to use whatever is available at your center in a timely manner. So I know very well that a lot of patients have a difficult time getting access to an echo or an MRI in a reasonable time, and in those instances, a MUGA scan may be the way to go. I'm not a believer in MPI for assessing LVEF. I know it's widely used in Ontario for other reasons, but I'm not sure it provides you with as good of an LVEF assessment as a true MUGA scan or an echo or a cardiac MRI.
I agree with you. The only caveat is if you use whatever is available, and with the shortest waiting list, especially after COVID. But if you want to reassess the mitral regurg, I think echo is probably the ideal one. And if you have a patient that you're worried, but like the LVEF is borderline, MRI can be very useful to assess the amount of fibrosis, and which is a risk factor for defibrillators. But you use whatever is available in the shortest waiting list.
Okay.
I would agree, Nick. I think that's the key message. You use what your local resources allow for. If you have resources at your disposal, access to an MRI, those are cases where you need to really finesse a decision and make you know, a finer point on either ejection fraction or other modifiers of sudden death risk.
And just to follow up on some of this conversation, do you guys have preference in terms of, like, if you have a baseline modality, what are your thoughts in terms of your follow-up modality being the same? Or do you mix and match like vaccines?
Like vaccines. We mix and match.
I personally, yeah, you can mix and match, but I like consistency. But ultimately, I think the decision still comes back to, you know, the patient has their LVEF initial assessment in Vancouver when they had their infarct, and then they go back to Prince George or you know, Whitehorse, and the only thing available is a MUGA scan. And you go with the MUGA scan, you're not going to wait or fly the patient at a significant cost to get that same modality.
Unless the quality of the echo was horrible, and so, well, cannot really assess, use the Definity to sort of see the borders, then you want to use another imaging modality.
But I think the thing to highlight is that there is a need for an LVEF reassessment, and I think that needs to be highlighted.
Mm-hmm. Okay. Oh, go ahead,
Picking
Mike.
up a question in the sorry, I was just picking up a question in the chat that somebody asked, and it just to add on to what was stated earlier. So somebody asked, is there a role for a Holter to look for non-sustained ventricular tachycardia when you're trying to help with decision making? So the other part of that question is, are there patients that we sometimes fast track for ICDs? We're talking a lot about giving medications time. Clearly, as heart failure cardiologists, we have a heavy bias towards the effectiveness of medications. But you know, what about other risk markers? Is there a role for Holter? And are there patients that we just say, you know what, time for an ICD? We're not going to fiddle anymore with 4 drugs or 5 drugs.
I'll let Anik answer that one.
Well, I'm afraid of fibrosis. I don't know if it's because I'm getting old or what, but patient with a lot of non-sustained VT on moderate dose beta blocker and a lot of fibrosis by CMR, I would really worry about this patient. Whereas somebody with no beta blocker, like three beats of or 4 beats of non-sustained VT within 24 hours, I think and no fibrosis, we could probably go along. But we often put ICD early on, and those patients that we're a bit scared about, especially if they're young, they have familial cardiomyopathy or ischemic cardiomyopathy with a lot of VT.
Yeah, I agree with that, Nick. I think that the three issues that come to mind are one, is there an ischemic cardiomyopathy or not? And if there is ischemia, then I think I would do that LVF assessment sooner rather than later if I can, and I would work on optimizing the medical therapy quicker. Two is the degree of fibrosis if we have access to that data. But I think the presence of significant non-sustained VT, I mean, if there's sustained VT, it's a non-question, right? So you diagnose sustained VT on a Holter, then especially with low EF, then I think you're kind of stuck putting that ICD almost immediately. But non-sustained VT, significant burden of non-sustained VT, I think that would sway me towards putting that ICD sooner than later, especially in an ischemic patient who is on good medical therapy already or a beta blocker.
Okay, so I think we maybe have time for one more question here. And it's more around, I guess, some tips. The question or the comment is tips on key messages to patients, particularly when up titrating GDMT instead of proceeding to device, when they typically have some side effects or their quality of life is an issue. Do you guys use this particular blood pressure cutoff? What do you do perhaps when they have renal failure? Just some, I guess, general tips from the field.
As a rule of thumb, they usually have too much diuretic, especially if they're dizzy when we increase the vasodilator. And some patients have been told to have a very strict fluid restriction, 1.2, 1.5 liters. There's no data to support that. In fact, there's data against 1.2 liters. Studies from Brazil showed that they come back more into the hospital because you cannot sustain 1.2 liters. So less fluid restriction, cut down the diuretic, and try to put to separate the medication, change the chronology so they don't get like their 4 pills at the same time in the morning.
The other thing is we have to remind patients that device therapy is not a replacement for medical therapy, right? And the last thing the patient would want is an ICD that's going to go off multiple times because they're decompensated or because they're not taking their beta blockers adequately, which are very good at suppressing ventricular arrhythmias, of course. So that's I think an important point for practitioners to highlight to patients. Two is that we're not just preventing sudden death, but we're trying to improve quality of life, and in some patients, quantity of life for some patients. And most of these patients, in fact, all of these medications that we have listed in our foundational therapies and the others, some of the others in the second tier or the other 4, as they're called, also improve quality of life. And I think that needs to be brought up to patients so that they're aware of that. And to me, sudden death is a secondary benefit, sudden death reduction and avoidance of an ICD is a secondary benefit.
Dr. McDonald, anything to add?
No, I think you have to do your level best to try and titrate and give patients every chance at good titration of medical therapy. We have to recognize that in the real world, patients can have contraindications or intolerances because of their biochemistry, their creatinine, their potassium, because of their frailty and blood pressure. So while we one of the key takeaways from the guidelines is that whatever you're going to do with medications, do it quickly, because that way you're not extending the period unnecessarily long, whereby a patient could potentially benefit from a device. Because there's a whole bunch of patients that don't have prophylactic defibrillators or resynchronization pacers who would stand to benefit. So it's not that we're going to kick the can down too long, so to speak. We want to get patients well optimized, get a chance to improve their heart function to the extent possible quickly, and then get the referral triggered for device therapy. That's probably the main message. Do what you're going to do, but do it as quickly as you can.
Okay. So I think for time, we're wrapping up here. Mike, I don't know if you want to field any more questions, or we should call it.
No, I think the hour is up, and we've had some good discussion. I had some questions in my mind, and I think the discussion that we've had is covered off most of that ground, actually. So I just want to reiterate my thanks to everybody for their attention. It's later at night for some of us, earlier for others, but hopefully that discussion was helpful and resonated with what you see in the real world. Over to you, Sherry.
Okay. So I think I would agree with that. We had some really good discussion. I just, in terms of housekeeping, wanted to thank everyone for joining us tonight, but also wanted to remind you and have you save the date for our upcoming webinars. So there's an atrial fibrillation webinar, webinar 2 on July the 8th. And then there's also the 4th webinar on the heart failure guidelines, which will occur on July the 15th. And just so you know, that these sessions and today's session will be recorded, and it will be posted on the CCS website shortly. So, you know, if you only made it for half and you want to see what we talked about earlier, you can join, or, you know, share it with your friends, because, you know, everybody is off isolation now and has nothing else to do, right? We want to thank you very much for joining us, and have a great night. Oh my gosh, Mommy.